Hello, everyone. I'm Shanta Jackson, founder and chief executive associate of Cause Engagement Associates, also known as CEA. Welcome to our 2018 quarterly webinar. Last quarter in March, we discussed LGBTQ plus client and patient outcomes, in particular, how to improve those outcomes. And today we're going to discuss community engagement, how to engage diverse populations for community health. But before we do that, I'd like to take a moment to tell you about CEA. Our main office is located in the DC-Baltimore area, but we work with clients across the U.S. virtually and in their local communities. CEA provides consultation and training to public health, healthcare, social services, nonprofit, and research teams across the country to plan, implement, evaluate, and share the outcomes of their stakeholder and community-engaged initiatives. Although our services are fluid in nature, meaning that we easily adapt to our clients' needs, we have three primary service categories, and they are: one, consultation and performance assistance, and performance assistance is just another fancy word for technical assistance. And we also provide training and workshops. And finally, we work with organizations to assess their capacity and readiness to effectively implement community-engaged initiatives and actually evaluate those initiatives. If needed, CEA will also provide additional services such as team coaching and staff training, and of course, more information is available on our website. For today's discussion on community engagement, I want you to walk away understanding certain key terms and their roles in producing culturally responsive community engagement and community health outcomes. And also, I want you to know how to distinguish the different types of community engagement strategies. I'll focus on two, one of which I highly prefer and recommend. And three, I want you to be familiar with the various principles of community engagement. There are actually 9 that are described by the National Institutes of Health and the Department of Health and Human Services in their free publication entitled Principles of Community Engagement. So again, Principles of Community Engagement is the name of this publication, and it is available online. Also, I will provide you with examples from the field that I actually implemented throughout my career in community engagement. For all the participants on today's webinar, please know that I am challenging you. I am challenging you to rethink your role. I am challenging you to rethink your organization's role and your community's role when it comes to building and sustaining relationships and practices to achieve health equity and to improve the health outcomes of the communities you serve. This applies to individuals actually engaging with community members and stakeholders, and also principal investigators and evaluators of community-engaged initiatives. So during the introduction, I mentioned that there are key terms that I believe that anyone involved in the planning, implementation, or evaluation of community-engaged initiatives should know. And you should know this, understand this, and incorporate this in your work. There may be more terms, but at the end of the day, I think that if you make these terms a part of your community engagement value system, you will be able to effectively work with diverse populations and produce better program and health outcomes. The first term, health equity. Health equity is not equality, not equality, not equality. Certain groups of people need more services, resources, accommodations, etc. than others. Health equity is adapting new policies, procedures, providing additional resources, access, services, and so on to eliminate health disparities or disproportionate health outcomes within a group of people or a community as a whole. So think public health, population health, and community health. And so next is health literacy. So health literacy goes beyond providing information at the 4th or 5th grade reading level or having documents translated into other languages. Health literacy is making sure that the community you serve actually understands the information being provided to them. That's one, that they understand it. And in addition to understanding that information, are they able to apply or use that information to make decisions about their health? So keep this in mind when you are developing educational materials, campaigns, surveys, etc. So next we'll move on to cultural responsiveness. Remember that one size does not fit all. Just because an initiative or an evidence-based program worked as is, or quote unquote as is, in one rural community or amongst a group of African American teens in New York does not mean that modifications are not needed to address the norms, stigmas, culture, traditions, needs, desires of the rural community or the African American communities that you serve. So before you possibly offend the community members and the stakeholders you intend to serve, intentionally learn about their culture. Recognize your insecurities, your biases, your preconceived notions, and put them away. Be intentional about learning about the community you serve and adapt accordingly. Be sure to document your strategies as well. You documenting your strategies and sharing your strategies is your contribution to the field of community engagement, community engaged research, philanthropy, public health, etc. Stakeholders and gatekeepers help to give you insight, access, or introductions to the communities you intend to serve. So again, stakeholders and gatekeepers, they help to give you the insight or the access or introductions to the communities you intend to serve. Stakeholders can be members of community organizations. A stakeholder can be your local city council person, civic association, or local public health department. Your community gatekeeper is that individual who can influence or give you access to certain people. So for example, that can also be your local city council person, or it can be the neighborhood barbershop owner, a baseball coach, a secretary, a church leader, or even a gang leader. So knowing who these people are as early as you can in the community engagement process will be beneficial to your community engagement strategy. So the sooner you know who your allies are and who will support your efforts, the better. And the sooner you are able to assess community engagement challenges and opportunities for improvement, the better. Next, we will discuss principles of Next, we will discuss principles of community engagement I find beneficial and that you can immediately incorporate in your community engagement planning and evaluation activities. This information is also useful to include in your proposals, etc. So what is community engagement? Community engagement is more than outreach, remember that. So community engagement is actually involving the community, collaborating with the community, and mobilizing the community. To the right, what you see is called the social ecological model, and your community engagement activities can be targeted to groups on these multiple levels of society, or your intent or target for your outcome can be applied to multiple levels of society. So we have the individual person, but then we have the interpersonal level, and so that's where we would include family, a provider, maybe a community health worker, a patient navigator, or a friend. And then on the organizational level, this is where we're more so focusing on working with or targeting those state and local health departments, your federally qualified health centers, professional organizations and associations. And then on the community level, we have media. Don't forget about media. So I would say that media would be on the community level. We have research institutions, community-based organizations. We have coalitions and collaboratives. We even have employers or work sites. And then on the policy level, an example of a community engaged initiative as far as the target population, or even just the program outcomes or your goals or your objectives, could be targeted towards clinical guidelines, screening guidelines, federal or state laws, clinical program policies. And one example that I saw recently on the policy level as it relates to population and community health, the American Cancer Society, they just recently released their new screening guidelines for colon cancer. And so now the recommended screening age is 45. It used to be 50. And the reason why I noted this, or I paid attention to this particular guideline, is because one of the examples that I'm going to show you from the field is related to a barbershop initiative, and the topic was colorectal cancer. And at the time, the recommended screening age was age 50 for the general population. But however, for African American men, or African American men and women, the recommended screening age was 45. So, so anyway, this is an example, the American Cancer Society. So I thought that was a really good example to share. Earlier, I mentioned that there are two types of community engagement approaches that I would like to share with you. So they are traditional community engagement approaches and participatory approaches. At CEA, we prefer to use participatory approaches whenever possible. There is another option that I've seen done that we can call the not so best practice option, which is using only existing data and stakeholder priorities to conduct your community engagement efforts. And so with this one, you have no community input whatsoever. Again, you're looking at existing data, your stakeholder, they have their goals, objectives pretty much set, and you're just kind of going out there and you're implementing the program with no input whatsoever from the community. And so as it relates to traditional community engagement, I would describe that as having community input via surveys, focus groups, interviews, community meetings, etc. And with traditional community engagement, you are intentional about being culturally responsive, and you adapt your program, intervention, or activities accordingly. You may recruit or involve community members to help carry out or facilitate some activities, and you make sure that you share the progress and the results of your work with the community. So that's traditional community engagement, which at minimum we all should strive for. And participatory community engagement is when there is shared decision-making within the community. You're focusing on capacity building and sustainability. So for example, you can have your community advisory board, or you have your coalitions. So with your participatory approaches, you're involving the community. So it's beyond doing a needs and strengths assessment. It's actually involving community members and maybe even training them to help administer surveys, to help facilitate focus groups. So you're involving them again with that process. You know, what do these surveys look like? What do these questions look like? What are our priorities, or what should be our priorities? Where for our community engagement strategy, which zip codes, which areas, which part of the community do we want to target first? You should involve your community members, you know, just in that process. And so this goes with the needs and strengths assessments, even the planning of your community engaged initiative. I know that sometimes we acquire these evidence-based initiatives, but that doesn't mean that you can't do those yellow light or those green light adaptations. So red light adaptations are just a definitely no. That means that if you make certain changes to the program, that you are not following the fidelity of that program. So you don't want to do that, but you still can make certain adaptations and still maintain the fidelity of the program, meaning that the program is implemented as intended. And so it's important. So if you want to be culturally responsive to those communities that you're serving, why not have them involved, and why not have them assist with some of those modifications or developing additional materials, or even kind of choosing some of the imagery for the educational materials, et cetera. And that goes the same for implementation and evaluation. Why not have the community that you serve a part of the evaluation process? They can help with the recruitment, they can help with the actual dissemination, and they can be the people to disseminate for you. So those are my examples of traditional community engagement and participatory approaches. I hope that I explained that well. You are also more than welcome to contact us. My contact information is on the final slide if you have any additional questions, and I also welcome suggestions. So earlier I mentioned that that NIH and the Department of Health and Human Services, so National Institutes of Health and Health and Human Services, they have a publication called Principles of Community Engagement. And so what I'm showing you now is the community engagement continuum. And so it's kind of a recap of what I said, of everything that I've said, but it's just in front of you. So it's to increase level of community involvement, impact, trust, and communication flow. You have, your outreach, you consult with the community, you involve the community, you collaborate with the community, which is important for that buy-in, and this is where you build your trust, and then this will help with sustainability. And again, that shared leadership. So again, that shared leadership and that shared decision-making, that's a part of your participatory approach. So before starting a community engagement effort, it's important that you be clear about the purposes or goals of the community engagement effort and the populations or communities you want to engage. So focus on overall community improvement and ask community members to specify their concerns, and also not just their concerns, but their needs, their desires, their assets, their strengths. Ask the community how they define quality of life. What's the ideal lifestyle or ideal quality of life for that community? Sometimes we go in and we set our standards of how things should be, but you definitely want to get the input from the community, and you can do this through your needs assessment process. And then also, again, I encourage everyone to have a community advisory board, and this community advisory board, what this would look like in my mind, not just stakeholders from various agencies or from your local government, but actual community members. So sometimes I go to various coalition meetings and et cetera, and I'm not seeing actual individuals from that targeted community at the table. So just keep that in mind. So also another principle, the second principle, is you want to become knowledgeable about the community's culture, economic conditions, social networks, their political and power structures, their norms and values, demographic trends, history and experience. So this process right here, this is the process, the ongoing process of being culturally responsive, which we talked about earlier. So for engagement to actually occur, it is necessary to, of course, you want to go to the community, you want to establish relationships, and you want to build trust. And so in building trust, understand that it may take time. You may not actually implement the initiative that you intended to implement. It could be until 3 to 6 months later. For example, you may go into a community and your topic is diabetes. And you talk and you're working with community members and you have them involved because you're practicing that shared leadership model, that participatory approach. And they say, you know what, diabetes is important in our community. However, we don't have safe playgrounds. We don't have a walkable community. We don't have a track, or I don't have child care assistance. And so there may be other things that you may have to address and assist with, and so that's where you want to work with your formal and informal partners and leadership on that. So you may have to sometimes provide other services. So this is where we're focusing on those social determinants or those social influences of health, right? That other people may have different needs, and then you help to meet those needs, and then you'll have more buy-in for that diabetes initiative. So again, seek commitment from community organizations and community leaders as much as possible. And remember that the community has the right to choose their level of involvement. And there are internal and external factors that may affect their level of involvement. And the best practice is to allow the community to define the problem and the solution. So yes, we have epidemiological data, and we know the social and behavioral data trends. We have our community indicators. We're really smart. We know what the community needs, but at the same time, this is your opportunity to meet them halfway and again, kind of involve them in the decision making and kind of let them define the problem. And just, that doesn't mean abandon your efforts or your initiative or your intent, but just be willing to modify and to change. And then also, partnering with the community is necessary to create change to improve health. That's why we're talking about this. And then number 6, the 6th principle is all aspects of community engagement must recognize and respect the diversity of the community. So that's getting to know their norms, the political and power structure, what stigmas are in the community, and et cetera. So that's how you just be intentional about being culturally responsive. And they will recognize that and they will appreciate that, the people that you work with. The 7th principle of community engagement is that just recognizing that community engagement can only be sustained by, again, mobilizing the community to identify their needs, assets, and strengths. It's not just about needs. Every community has some asset, some strength, some resource, something to be proud of. If you can work with them and focus on what the good and what they are proud of, that, in my experience, that helps to address what the issues are and what the problems are later on down the line. And so develop that community's resources and capacity to make decisions and to take action. And that's the purpose of a participatory approach. So we can go into a community and we can do community engaged initiatives, and then we can step out, or we can decide to say, you know what, I want to help to improve the capacity of this community. I want to make sure that we have trained health educators or trained community health workers. I want to make sure that that there's funding to, for sustainability in the community, et cetera. So that's what you really want to focus on when you're working with the community. It's not just we have a good idea and we want to implement this with you, and we intend to help you. But if you really want to help someone, help to share your skill set. Share your skill set, provide resources, show them how to access resources, how to utilize those resources. Again, consider health literacy. Do they really understand the information that they're getting? And are they able to use that information? So that's your responsibility. And then the 8th and 9th principle, so number 8 is be prepared to release control of actions or interventions and be flexible enough to meet the changing needs of the community. And then number 9, just understand that community collaboration requires long-term commitment. So this is long-term commitment by your organization and also by your partners that you're working with, because that's the only way. So we have short-term goals, we have intermediate goals, and we have long-term goals, and we want impact. And the only way to get to those those long-term goals and to measure our impact is if we are committed in that community for the long term. So examples from the field: mobilizing Black barbershops and salons to promote healthier communities, and a school health and wellness at an Islamic private school. So first I'll talk to you about HARE, Health Advocates and Reach and Research. And so this is actually an ongoing initiative by the Center for Health Equity in the School of Public Health at the University of Maryland in College Park. And with HARE, basically what they do is they recruit barbershops and beauty salons, majority barbershops, and in particular these are Black salons and barbershops, and they transform them into what they call health information portals, and they create opportunities to develop health messages and different services, and a dialogue about health and community engaged research. In this particular network, we recruited 10 barbershops and beauty salons, so actually 8 barbershops and 2 beauty salons in Prince George's County, Maryland, and we had one in Montgomery County, Maryland, and one in DC. And so the main initiative that we really focused on for 2 years was a colorectal cancer prevention initiative. But in doing that, or before doing that, one of the things that we did is we brought in healthcare providers. So this is the building trust aspect of this. So we brought in healthcare providers from local hospitals. They provided various health screenings such as blood pressure, carbon monoxide, BMI, body composition. We had a hospital that actually had funding for free colorectal cancer screenings, and so they came into the barbershop. We had various agencies for education, advocacy, just various organizations, whatever we can find that we felt was beneficial to the community, and whatever the barbers told us that was beneficial, we brought that in. And then that's when we introduced the colorectal cancer initiative. But before we did the colorectal cancer initiative, we also, so the University of Maryland, they conduct at the Center for Health Equity community engaged research. So they had various research studies throughout this network. So this is an ongoing, sustainable network of barbers. So with this colorectal cancer initiative, what we did is we developed a facilitator manual to train the barbers and stylists on how to be health advocates for colorectal cancer. So we recruited 4 barbers and stylists from each salon. They participated in a 3 to 4 hour training, and they were trained on how to be health advocates, not health educators, for colorectal cancer. And some of those studies that we talked about, as you can see here on the screen, we actually used real images of the barbers and stylists that we work with. So again, we have that buy-in, your community engagement. And what I'm showing you now is an example of traditional community engagement, meaning the barbers, even though they participated in the training and they were supportive of the of hair, and they are members of hair, at this point, they were not involved in the decision making of the activities. So this is your traditional community engagement. And so what I want to show you next is an example of a participatory approach, and this was conducted in an Islamic Muslim school in Prince George's County, Maryland. And again, this was on the behalf of the Center for Health Equity at the University of Maryland. So that's me in the center, and to the left, the woman in the hijab, she was my liaison for this program. So sometimes you have to kind of recruit that, again, that gatekeeper, that person who can kind of help you to navigate that community that you're not familiar with, that community that is very, very diverse. So if we look at the last square, we see spring 2016, we implemented a nutrition program called Produce of the Month. But before we implemented that program, that intervention, for about 3 years, we had to do other activities to build trust with this community that we had never met before. So we had an initial meeting with them to kind of gauge their interest. So them would be the principal of the school and the vice principals. And we developed a committee with the teachers and staff called the Healthy Al-Huda Committee. And during these monthly meetings, what we did shared decision making, shared planning. And so together we decided that in order to introduce concepts of health and wellness and to get familiar with the Al-Huda community meaning the school, the parents, and then the outside, just the overall Muslim community in the area, that it probably would be best to introduce or to have a project together, still focusing on health and wellness, but not a particular topic. So what we decided is to develop a cookbook, and we had a cookbook cover contest. We met with the teachers. We actually hosted an event with the parent-teacher-student group that they planned and that they coordinated. So again, that shared decision-making and responsibility. And we sampled recipes from the cookbook, and then we were able from there to get a newspaper article. And then from there, so now we're in spring 2015, this is when we actually started the community engaged research. So this is when we hosted focus groups. We recruited teachers and they were trained on the facilitation of the focus group. So they co-facilitated the focus group. We released the cookbook, and then we started implementing. Now from those focus groups, we now know what health messages to provide. So now we have these weekly newsletters, and then we have our intervention, which is Produce of the Month. So in building trust, what you see now on the screen are just examples of things that, so we learned a lot, and that was and this is why we had the Healthy Yahuda Committee, and this was the benefit of having them, so they could tell us, what was appropriate and what was not appropriate in the school. So the existing materials that were available from USDA, so My Pyramid, they were found to be inappropriate and had to be translated for use in Al-Huda school. So in particular, what it is the figurative depictions. That is not appropriate for this conservative Muslim school. And so again, we had the students involved in the design of the cookbook, and this particular school, and I think this is important to note, that this school is diverse, and they represent, the students represent, or their parents represent over 50 different countries. So it's very diverse. So sometimes not one size fits all. And so this is just us kind of going in and we're just learning, right? So again, the students were involved in the process. So again, this is a part of our building trust. And these are just images of the meet, greet, talk, and eat events that we had. So again, we developed a cookbook. The parents submitted recipes, and we, in the actual cookbook, we had nutrition labels for each recipe. And this is us kind of building trust with that community. So by this time, they're excited about the partnership that we have, and so we're featured in a newspaper article, and then we're able to conduct focus groups. And so to the right in brown, we're targeting the brothers of the community because the sisters had spoken and we were having a hard time reaching men. And you'll notice we kind of asked them, which days are best for you to contact you, and so we would plan the focus groups around them. And so again, we had the input. This was designed, the content was from the Healthy Yahuda Committee, so they were actually, again, involved in the shared decision making. And as a result of that, we were able to conduct those focus groups, and what we learned is that students were embarrassed of their tradition because they're in the U.S., and again, there are students who their parents come from different countries. So for whatever reason, the parents said that their children were embarrassed, and so they did not want to bring some of those healthy foods to school. And then also, we noticed that the parents equated junk food with American food. And then also we found out that there were a lack of resources in the school. So they didn't have a kitchen, they didn't have space for physical activity, so they did not have PE, and or they didn't have exercise equipment either. So on to Produce of the Month. Produce of the Month was originally implemented with the Southern Nevada Health District in elementary schools in Clark County School District with 4th and 5th graders, and Al-Huda was modified and changed for 2nd and 5th graders. So we had to make some things age appropriate. And the modifications that we made that did not affect the fidelity of Produce of the Month were we separated the classes by sex. We incorporated presentation slides for the physical activity components that require dancing. There was absolutely no dancing because that wasn't appropriate, and no figurative depictions. And again, we would not have known this if we hadn't worked directly with the community and if we hadn't used that participatory approach. In Healthy Yahuda, we also included religious references, and we had an institutional review board process. And again, we applied those participatory approaches versus the original Produce of the Month did not. And what you see in front of you now are just examples. It's something really simple. So again, we worked directly with the teachers to develop the PowerPoint slides and but this is just to show you how we incorporated religion. So vitamin A. So normally we would say vitamin A helps to keep your eyes and skin healthy. But in this particular instance, with this community, if Allah allows, if God allows, vitamin A will help to improve your eyesight and skin growth. And then we also made sure to encourage the children to pray before and after they ate their food. And you can see some of the images that we use. Again, we have no figurative depictions. And again, if Allah allows or with Allah's permission, physical activity produces certain positive results. And again, a prayer before and after. So this was incorporated. So we had to pause and we had to make sure that the children said their prayers. And that's pretty much it. I appreciate your time, and I appreciate you wanting to, to learn more about what I have to say and what Cause Engagement Associates has to say about community engagement. This is free educational content. Of course, we are resourceful, and there's more and more to talk about. If you're interested in working with us, or if you have any additional questions, feel free to email. You can actually email me directly, or you can call our office at 240-560-3711. And then also you can connect with us on social media. And I am on LinkedIn, and so my LinkedIn is how you see my name now. It's Shanta Jackson, MPH. So please connect with me, and thank you for your time.